Hello, everybody. It is now 1:05 Eastern Standard Time, so hopefully have the chance to join. We're here today with Dr. Trock. Let me pull over to these slides. All right. Everybody, welcome to Veins in Motion. Does an active lifestyle remove the risk of vein disease? My name is Amber Davis. I'm a marketing associate with Sigvaris Group, and I'm excited to introduce our speaker today, Dr. Trock. Dr. Trock is a doctor of physical therapy and lymphedema specialist and the director of clinical operations at Medical Vein Clinic in San Antonio, Texas. So, Dr. Trock, thank you so much for joining us.
Thank you.
Renee, have your little intro slide here.
Okay.
And we will have the opportunity for a Q&A at the end of the webinar. So hang out if you have any questions, and there's a Q&A chat box, and I'll read them out loud and Dr. Trock will answer them. So, but for now, Dr. Trock, if you would pull up your slides, we'll see if that works.
All right, let's get this set up. Should be up now?
Perfect.
Did you see it? We have it. Excellent. All right, ready to go.
So take it away.
Perfect. Awesome. Well, thank you, Amber. Thank you, Sigvaris, for allowing us to have this fun presentation. Good morning, good afternoon, good evening, wherever you guys are in the world. Thank you for taking the time out of your day to spend an hour with me to talk about a subject that is something that's really important to me, something I've spent my entire career dedicated to, which is the combination of the venous lymphatic world and then functionality, what we do in physical therapy of helping people live their best life. All right, let's walk through this now. All right, here's my disclosures. So a little bit about me. I really have dedicated my whole career just kind of circumstantially to the lymphatic venous world. I've been doing it now for 13 years. I started off in home-based therapy where I saw the worst of the worst lymphatic patients, wounds, that whole thing. And it was very, very rewarding, very challenging, both mentally and physically. And during that whole time, I always thought to myself, how do these individuals that are so very advanced get to that point? What was it? What led them to this situation? And you walk things backwards in time, and where was the point in that person's life where an intervention, some medical professional could have gone and done something? And that's what we get to do now here at Medical Vein Clinic, to help these individuals at that critical nexus point in their life to make a difference. And that's what got me thinking about this topic, because these are individuals that I've seen many, many times. These individuals that something with exercise, something with their veins, something doesn't seem right. And it kind of goes against the conventional knowledge. And that's what we're going to dive into today. So I'm going to ask a non-controversial question. Does exercise, is it always beneficial for treating venous disease? What do you say? What do you say to that? Is it always beneficial? Well, I think a good starting point for this is what we typically will say in the medical world is, well, it matters. It does matter. Is it the same for all people? Is exercise the same for all people? Is all venous disease the same? Is the application of therapies, both conservative as well as interventional, do they have the same efficacy for all people? If you've been doing this for any length of time, you'll probably say no, because there's so much variation between patients and the circumstances that they find themselves in. So generally speaking, I would say that having someone who's diagnosed with vein disease exercise more would be a good thing. However, within that, I will say that there's a subset of individuals where this topic is much more nuanced, and that's what I'm hoping to show you all today. So to lay the groundwork, we have to define what is a healthy venous system compared to a dysfunctional system. Now, I'm about to get into some anatomy and physiology and all the stuff I like to nerd out with. So make sure you've had that second dose of caffeine, because I do not want to lose you. This is so important. We're going to start with the basic circle of circulation. When we are discussing this to patients, generally there are 5 components we want to touch on: our heart and our lungs and our chest, our arterial flow down distally, our venous lymphatic flow to return it back, to complete the circle. Even at that level, as we talk with most of our patients, this is a concept that is pretty foreign. And it's important to lay this groundwork because we need to understand how much blood there is, how much blood is moving, how and where the difficulty points are. So as you look through this slide, we see arterioles going out, going through the capillaries, and then we see a second series of tubes that bring it back up, which is that venous lymphatic system. And generally speaking, most individuals, most adults have 5 to 6 liters of blood that's rotating on a very regular basis, roughly every single minute. And we look at capacitance of where this blood is residing. The vast majority of it is in our venous system. So thinking about that, there's going to be a stress there just because of that higher volume that it holds on to. Now, where all this stuff connects, as you'll see, is the capillary. And I'll dive more a little bit into it, but our capillary system really does dictate so much of what we're going to talk about today. So we have to have a basic understanding of it, because this is where our arterial venous lymphatic system meet. And there's a lot of capillaries. By some estimates, there's 10 billion capillaries in our body. And if you took one individual and all of their capillaries and stretched them out side by side, it would stretch over 60,000 miles. It's amazing. It's absolutely amazing what these things are and what they do. But first, let's get into veins. So what are veins? Veins are low pressure mechanical system. They are the return vessels. They bring everything back to our central cardiovascular system. They carry deoxygenated blood. That's the difference between the blue and the red, is their oxygen content. And they're heavily reliant upon motion or external kinetic energy. They don't have a natural rhythmicity, and they don't really have a rebounding effect of what occurs in the arterial system. And our leg and venous anatomy are slightly different, because if you look at this chart here, our arms are at a different level to our heart than our legs are. So they operate with different types of pressure. So when we look at venous functioning, the key thing that we have to rely on is our musculature. So we look at this imaging here, and you can see the muscle squeezing the vein, propelling the blood more proximally. And what's interesting is we start off with a lot of tubes distally. So when we look at our legs, there's a lot in our feet and our lower legs, and they converge as they move proximally up to a singular point in our groin. And they move from out to in. So it's out to in and then up. And they move through what's called perforating veins, which are the connecting veins that bring all of this blood flow back up. Now, valves are interesting. Valves are very, very cool. I want to show you this video. So this is an ultrasound I did of myself. I was looking at my Achilles. I thought I had hurt it, so I wanted to look at it with ultrasound. And as I was doing that, I stumbled upon the start of my greater saphenous vein around my Achilles. And you'll see the blood flowing from right to left. We have amazing equipment here at Medical Vein Clinic, so we get to capture such beautiful images. And you can see my valves, that they are. They're closer together distally, so in our leg, and then they spread further apart. They go from about every inch to every couple of inches. But you can see the valves, the bicuspid, they connect if it was closed down. I'll show you another image here that shows how that works. So you look at the left, a healthy vein, it's skinny, it has valves that come together, and blood moves essentially from valve to valve to valve. It's like a ladder system. And then you compare that to a diseased valve where it is a greater diameter, the valves are pulled apart, and so you see backwards flow or reflux or regurgitation. Additionally, what happens is those valves are pulled apart. We'll see here, it's an image right here, kind of within this area underneath the valves. You can see my little laser pointer there. It causes turbulent flow. It actually changes how the blood moves. So instead of one directional, it starts to move in a side by side, which diminishes flow as well. So there's a lot of negative mechanics that start to occur as these veins start to get larger or change shape and the valves stop working as well. But just remember, the two things that we need to move blood from our feet back up is we need healthy veins and we need energy to move it through the musculature. So when we look at venous disease, so veins that are not functioning well, where we have backwards flow, it's pretty extensive. I've done a lot of research on the prevalence of venous disease, particularly in the United States, and the research is really all over the place for it. But a good estimate is around 30 million individuals in the US, and I actually think that's a number. And so that is roughly 10% of the US population. But what's interesting is that within that, only 7% ever seek treatment and less than 2% actually receive treatment. So that's incredibly low of what's out there to what's actually being taken care of. And when we look at the direct costs, once again, wide range of costs in the US is between 150 million all the way up to $3 billion annually for venous disease. And most of the newer research has shown it higher. And what's interesting even within that is it's not including secondary effects like progressive lymphedema and cellulitis and some of these more concurrent conditions that are rather severe that potentially and oftentimes come from untreated venous disease. So I actually think that number is much higher. And then on average, an individual will have venous disease for 35 years before receiving treatments. On average, I think the typical age we see here in the clinic is between 55 and 65 years old, which means for those individuals, their venous disease actually started in their 20s and then has progressed from there. And that's the thing with this, is it's like a self-fulfilling prophecy. Venous disease continues to progress and damage the system, as I'll show here in a little bit, and not fix itself. And so we want to intervene sooner because it's better for everyone when we do that. Now, what's important to understand is prevalence. If you're a medical professional, maybe you're in primary care, and you're seeing individuals that are coming in that are sick, that have symptoms, and trying to figure out where this stuff is coming from. Well, this is a great little chart showing comparisons of venous disease, venous insufficiency, to things like PAD, arterial disease, or congestive heart failure, stroke, AFib, those sorts of things. And you can see here it's much more prevalent. Even in this chart, I quoted 30 million. Well, we know this chart only goes up to 25 million. So I think the comparison is much greater and much greater stark contrast for that. And I'm going to talk a lot about swelling and edema here in a little bit. And that's, keep that in mind as maybe, once again, you're in a primary care setting and you have someone that has distal leg edema. Well, if we're going to go with the odds, the statistics on all of this, you see some swelling and that's about it. You work them up through congestive heart failure and going through that whole route, or let's check them out for venous disease and see if maybe that's the reason why this is happening. Just in terms of our clinical decision-making, what are the odds ratios going to be telling us? When we talk about prevalence, it's a hard thing to track because most of the research done historically on venous disease has been self-reports or something where they were using basic symptoms like just varicose veins and neglecting a lot of the others. So it's hard to find that out. This is a phenomenal study I stumbled upon where it was the University of Maryland Medical Center did a study where they just looked at all of their healthcare workers. And this could be nurses, doctors, office staff, and they just left it open. They said, come for a free screening for venous disease. So in this study, they had 636 participants. That's a good N on all of this. And when we look at their kind of standard demographics, 42 years of age, so on the younger scale, body mass index, a BMI of 29, the lower end of that, and they were relatively healthy individuals. Well, going through this, they found that 72% had occasional leg pain, which is a typical symptom of venous disease, and 42% had evening leg swelling. And that's most likely underreported because swelling is a hard thing to catalog, but this is what the obvious swelling is. But yet within that, 2.7% actually were compression, typical of healthcare professionals. Right? And what I love about the study is they actually did a ultrasound of every individual that came through. And this is what really, really stood out to me, is that 71%, so nearly 3 out of 4 of these individuals actually had active venous disease going on. 71%. And in the ultrasound study, they just analyzed 3 areas: the deep femoral vein, popliteal vein, and then the sacral-femoral junction. They didn't even look at the superficial system, which may have even showed more prevalence. And so when we look at prevalence scores or prevalence in the community, I actually think it's a lot higher. And this is a great study that shows that. One that's also of note is they did what's called a Caprini score, where they were looking at their risk factors for developing a blood clot. And 14% of these individuals who are healthy healthcare workers, healthcare professionals, were at a very high risk for developing a blood clot, which is quite remarkable there. So just keep that in mind as we're talking about healthcare professionals and the prevalence in that sort of demographic. And if you yourself are a healthcare professional, odds ratios are you have some venous disease forming, and we'll talk about it a little bit later what we can do about that. There we go. So when we look at why venous disease happens, what are the things that lead to this? We're going to start with genetics, your family history. If you have one parent that has venous disease, 50% odds, just straight off of that. Both parents have it, most likely you're going to get it. And then we start compounding things. So we have age. We have the opportunity to build up negative things to impact this mechanical system. So we look at, over 30 years of age. And then we look at things like mobility. So sedentary lifestyle, which most of the individuals we talk to in our clinic have office jobs. They're sitting the majority of the day, or maybe they're retired and they enjoy The Price is Right and novellas all day. They're sitting all day. Or maybe someone's developed a mobility deficit. This could be something that's orthopedic. Maybe it's after surgery and they're not moving around a lot, or they have some sort of condition like a stroke or Parkinson's disease or MS. All these things that affect that calf muscle pump and the ability to move will also impact this system. Weight, a BMI over 40 puts you a higher likelihood of that. In the female population, multiple pregnancies are another risk factor. History of trauma, surgery, once again, immobility. Things like knee replacements. There's a lot of really good research showing its negative impact on the lymphatic and venous system. Tobacco use, smoking, definitely previous blood clots had a huge impact on it. And then even central cardiovascular disease, such as AFib, pulmonary hypertension, obstructive sleep apnea, which is even worse if the person should be using the CPAP or BiPAP and not using that. So you can see all of these components mixing together to damage our veins over time. So how does this manifest? If you're in a clinic, what are the things that are going to show what's going on? Well, there's 2 general categories I like to put together, which is things that you would see or a patient would see, or things that the patient would feel. So things that individuals would see, kind of general 4 categories for that. So the first are the classical, things like the spider veins, the bulging veins, those sorts of things. So you can see my little laser pointer here, this little spider veins up here. As they start to become more 3-dimensional, we call that a venulectasia. Those ones are more prone to bleeding just because of how thin the wall is to that. If you start to see a mound of purple veins around the medial ankle, that's called corona phlebectasia or crown of veins. And then we look at reticular veins or large bulgy varicoses down here. It doesn't take much to make a vein pathological. Really, it's anything over 5 millimeters of diameter, so it's not much. And you go back to those previous slides showing that large engorged vein and what happens to the valve. Well, the blood just moves slower in those situations. And so these are obviously visible ones, but based upon the 3-dimensional layer that they find themselves in, some of these won't be visible because they're deeper in the adipose layer and they're just not prevalent. Surprisingly, though, the 2 biggest things we see all day, every single day here in the clinic would be this: hemosiderin staining, that brown staining around the ankle, which is Erythrocytes, red blood cells trapped due to high pressure in the subcutaneous tissue. As they die off, their hemosiderin content, their iron oxidizes over time and creates that staining. And one thing I always like to emphasize, it is not merely cosmetic. It's actually dermatological damage that occurs. It actually affects the lymphatics at pulling up fluid, and it causes a chronic inflammatory state, which is why we start to see things like dermatitises and things of that nature, eventually wounds and all of that. So it doesn't have to be as pronounced. Maybe the medium malleolus, brown slight staining is the starting point. And, we think of these individuals here, well, they didn't wake up like this. This is something that is years in the making, and obviously something that we'd want to see sooner than that. And then we get to things that a person would feel. Now, this could be all over the place, but I categorize it in 3 general ways. So you have discomfort. So that would be feelings of heaviness, fullness, fatigue, ache, tiredness, as they would describe it. Pain is generally something that we don't see. I mean, it can happen, but it's not as prevalent. Normally, these symptoms are things that progress as the day goes on due to a buildup of fluid, which I'll show to you here in a little bit. You can also have concurrent neuropathic or radicular signs. So feelings of itching, tingling, numbness, burning, you can have some overlap with that as well, which is why it's important to use this as part of your differential diagnosis if you have someone that has chronic low back pain, glycation, diabetic neuropathy, to figure out where this stuff is coming from. Finally, interestingly, we also see a lot of cramping within the legs, as well as restless leg syndrome that occurs with all of this. And these are things that just can go on and on and on. Sometimes patients get used to it, but these are things that should be pointed to, do I need to do something about this? Do I need to figure out what's going on? And so I'm going to walk you through a case study. I'm going to walk you through the life, I'm going to call her Kim, an individual I've seen thousands of times in our clinic. And so let's walk through her case. I think it's going to be real illustrative of what we're talking about here today. All right, so let's meet Kim. So Kim is a 43-year-old female. Maybe she's a nurse, she's a teacher, she's an attorney. She's married, she has 2 children, aged 14 and 8. She's 5'5", 160 pounds, so she has a BMI of 26. She has a history of bad veins on her mom's side. Her medical history, she has hypertension, hyperlipidemia, she has anxiety and depression. She had her gallbladder removed at age 39, and she has had 2 C-sections. Does this patient sound familiar to you? Have you seen them before? Maybe this is you. Her activity. She exercises at 5 a.m. because she has a job and kids and everything. So she does it early in the morning, 3 to 5 times a week. She has a combination of high intensity interval training and cardio. And she walks around 5,000 steps a day. So this would seem like the average person that you may know, or you may be this person or be related to that. So she comes in and we do a full exam, and she reports, she says she has visible spider veins that worsened after her 2nd child. She reports feelings of heaviness, achiness, fatigue, along with slight palpable edema around the ankles that presents at the end of the day or after strenuous activity. Her goal, this is her goal, very important to know what everyone's goal is she wants to understand what is going on, why is this happening, and she does not want to end up like her mom. So we do a physical exam, and we find that she's got some spider veins going along the lateral aspect of her thigh, and she has it behind her knee. She has that brown staining forming on the inside of her ankles, and she has 2+ pitting edema by the ankles. When you look at her ankles, though, you don't notice that. You have to go and palpate that to actually find it, because it is not a very appreciable edema just by looking at it. We did an ultrasound then. And what do we find? Well, her greater saphenous veins, her small saphenous veins, and her anterior accessory veins on both legs are refluxing. They are wide in diameter, and there's certain volume of blood going backwards, as well as she has some reflux in a deep venous system. So our diagnosis, she has chronic venous insufficiency to both legs, and she has transient venous edema. So here's what we're going to start her on. It's so funny. I talked to this person about 3 times this morning. It's exactly what I told them. we will get them into 20 to 30 thigh high compression. And the goal is to wear that every single day, on in the morning, off in the evening time, especially during work. Why? What is that going to do? Well, it's going to take those veins, it's going to realign them and allow those valves to function better. So the body now has an opportunity for better venous flow, and we would expect certain symptoms to reduce. Now, here's the other thing I'm going to have her do. I'm actually going to have her start wearing sport style compression when she is exercising, because in this individual, there may be a circumstance where the exercise is making it worse. And we'll get to how that is actually happening. And so I'll get her into good quality compression to wear during exercise and some thigh highs to wear afterwards. We're going to increase her activity. She's going to ambulate more throughout the day, trying to hit those 10,000 step goals. And we're going to utilize positional changes. I'm going to have her elevate after activity where her feet are truly above her heart, about 2 feet or so, for about 10 to 15 minutes afterwards, to create a flushing movement to move that blood flow out of the legs. And here's what happens. Within 1 week, the symptoms she was experiencing, that heaviness and achiness, has reduced. She has no longer has visible edema at the end of the day, yet the spider couldn't remain. That's what it's. So, my question again, does this person sound familiar to you? And then the question then is, why does this happen? What is going on? What's the mechanism to this action? So now we're going to get into how edema forms. One of my favorite topics to talk about. So we're going to go back now to that capillary. So as you can see here, we've got the red artery, we've got the blue vein, we've got the capillary, we've got our lymphatics, and then we have our interstitial space, the spongy material that connects everything together. So here's how edema forms. First, you can have increased capillary hydrostatic pressure. Basically, what that means, as veins get bigger, backwards flow occurs, and we have a greater amount of pressure going backwards into the capillary, which then induces flow of fluid out into that capillary space. We call that passive hyperemia. Second reason why edema can form is there's a blockage or deterioration of the lymphatic flow. This would no longer be a creation of edema issue. This would be a transport issue. I'll talk to you a little bit about that. Increased capillary permeability. Now that would happen on the arterial side, which is what we are seeing down here. We call that active hyperemia, which happens in infections. It happens after an acute injury. It happens in diabetics, and it actually happens in exercise. It's an accommodating effect where there's a dilation of arteries to increase blood flow. It makes sense. We're doing an activity. We need more blood flow to that area. So it increases. And what happens is then that increases pressure, which increases more fluid going out into that space. Decreased plasma protein. So you'll see this in people who have malnourishment, low protein in their diet, liver disease, where you get that more sarca, that full body swelling going on. So essentially anything that disturbs this balance of forces inside or outside the capillary will create edema. And edema is not a normal symptom. It shows that there's something with homeostasis that's off. And to an extent, all edema is a form of lymphedema. And I like to put it this way, is this a transient or is it a chronic lymphatic insufficiency? Meaning, is the lymphatic system not able to keep up with the demands on it? Because that's the final thing with this is, and I won't bore you with Starling's principle now, but they used to think a certain amount of fluid would go back into this capillary. And the revised Starling principle through Calicks and all these other findings essentially showed that once fluid gets out into that area, it is not going back into the capillary. So what that means is once that fluid's out there, it is only the lymphatic system that is now moving this fluid. And that you have to understand that, because now you understand the importance of managing the lymphatic system and not stressing it or optimizing it in some way. So we're going to talk about traffic. I don't know where you live at, but here in San Antonio, we have a lot of traffic. And I use it as an analogy all the time for our lymphatic system. So there's 3 things you need to understand. The first is transport capacity. So that's the absolute capacity for our lymphatic system, or look at it this way, a highway to move fluid, meaning what's the most amount of cars you can put on the road without it slowing down. That's what transport capacity is. And then we have two other things: lymphatic load, how much fluid is being made, and then lymph time volume, which is the adaptability of the lymphatic system to compensate for increased lymphatic load. So essentially, as you'll see down here, as lymphatic load increases, our lymph time volume increases as well to compensate for that. Under normal conditions, we create about 10% of our absolute capacity. So there's a huge gap in between. It's called our functional reserve. And so when the body adapts to more cars on the road through whatever activity or whatever circumstance created it, we're fine. And we don't get swelling. We're okay. Well, here's what can happen. We can first create too much fluid. And that could be things like venous insufficiency, or on the arterial side, dumping too much fluid. Either way, too much fluid is being made. And as soon as we create more fluid than our body can handle, we get swelling. So that would be like traffic congestion. Another thing can happen, which is really the true lymphedema, which would be a decrease of transport capacity. So that would be taking a really wide road and making it smaller and smaller and smaller. So maybe after surgery or some sort of cancer treatment, that's where you would get that. However, most situations, it's a combination of the two, where we have an increase of lymphatic load while there's a decrease of transport capacity. So there's typically both things going on. So now we got that all laid out. Let's talk about activities and situations that could potentially worsen this sort of situation in terms of the venous lymphatic system. So first off, a genetic predisposition for CVI. And that could be someone who just naturally has dysfunctional veins, so they don't move as much blood and have naturally more backflow, or someone who has natural lymphatic dysfunction. We're not all born with the same type of roads and the amount of roads, so we have more predisposition there. Females more than males, part of that is pregnancy as well. And then having active venous reflux. So when there's a situation where things are going on where the veins are not working well. And I didn't talk too much about perforating veins, but in certain athletes, cyclists, for instance, they develop more perforating veins. If those are refluxing, essentially blood's gushing out from within the muscle, that would definitely exacerbate it. Higher the BMI, pro-inflammatory lifestyle. So these could be individuals that have a very poor diet, something that has a higher histamine content within their diet. People who drink a lot of alcohol, that sort of thing, or are on a lot of medications that are pro-inflammatory. Polar opposite days. So this would be individuals like Kim who would work out early in the morning and then maybe would sit all day. So you're inducing an inflammatory state through that exercise in the morning time, and then you're just sitting with all that fluid in your legs throughout the day. And then jobs with high venous demand. So maybe someone who works in the kitchen where it's really, really, really hot, or maybe a dry cleaner, or a construction worker that works outside. So they're on their legs all day, which is a high physical demand, and they're in a really hot environment. So challenging activities, what are things that would compound on top of that? So any exercise that has venous volumizing activities to it. So high intensity interval training, bodybuilding, strongman, powerlifting, steady state cardio, which I'll talk more about that here in a little bit, or long duration activities. For instance, we see a lot of individuals that will go to a theme park and they're not used to walking all those steps throughout the day. Maybe they do them multiple days in a row. Maybe they went to Disney or something like that. And they come back and they have all these worsened symptoms because of that. High demand sports, as I mentioned, things like chef or people who do dance or things like that. So one of the articles I was looking through was talking about venous adaptations in endurance athletes. So these were people who do not have venous disease. They wanted to see what would happen. And athletes develop a higher capacity. Their veins are bigger. They hold more volume, and they actually develop more perforating veins, which is great. It would make sense as an adaptation to exercise. But the problem is, if that goes south, they actually have more incidence or more likelihood of having worsening venous disease. For instance, one was looking at a professional cyclists and the propensity of very bad venous disease over time because of this big capacitant system that then becomes dysfunctional for that. This is a quote from this. It says, further questions arise related to whether the high flow experienced and repeated prolonged exercise protects against or contributes to the development of venous disease, and particularly remodeling associated with varicose veins or chronic venous insufficiency. And then going down, the impact of repeated endurance exercise on vein anatomy and hemodynamics is not yet clear. And this is a relatively recent article done in 2023. So now we get into exercise. What does that mean? You go and tell someone, go exercise more. Well, what in the world does that? So I'll make it very simple. There's generally 10 aspects of physical skill. So movement, what type of movements are we going to be doing? So we have cardiovascular, respiratory endurance. So your heart and lungs and red blood cells capacity to move oxygen and carbon dioxide. Stamina, your muscles' ability to do the same thing. Strength, how much weight can you push? Flexibility, movement through range of motion. Power would be strength over time. So if you took strength and speed, that's where you get power from, how much you can move in a shorter period of time. Speed, so sprinting movement, that's what we gate speed, Reynolds speed. Coordination, agility, which would be a combination of flexibility, coordination, speed. Balance, keeping your center of mass over your base of support. And then finally, accuracy, doing an external task well. So these are the 10 general physical skills. So we build all those together to build some sort of exercise for that. So the good ones are the ones that I found that would have the highest venous lymphatic demands. So cardiovascular endurance, stamina, possibly strength and power. And then I'm at a fourth component, which isn't on here, but heat. Heat exacerbates all of this. So increase of volume. So something that would be a high volume over a short period of time. So maybe a high intensity activity, short period of time. Or you could have low volume for a long period of time. So lots and lots of walking over a longer duration of time. And then obviously high volume, long time. So these are the four that we really want to focus on as potentially having an issue with overwhelming our venous lymphatic system. So I looked, there's not a lot of research out there. This is one that I found looking at physical therapy and pain, modifying pain and edema with venous disorders. And it was a systematic review. Not a lot of really good studies that they looked at because there's not a lot of very good research out there on this. But they looked at various things. So we had things from like yoga to Pilates, swimming, basics, low intensity stretching, aerobic activity, strength training, dance, sports, whether it's running, racket, team sports, body weight activities, rock climbing, gymnastics, martial arts, and then just manual labor and all that. So all these different things that they looked at. And what was interesting was this. When they looked at this, they found the most amount of effect was swimming, being in water, which makes absolute sense why that would be helpful, because when you are in water, there's a thing called hydrostatic pressure. Essentially, the deeper you are in water, the more external force. And if you're standing in water about chest height, it is just like we're in a compression garment. So I would expect someone who had venous disease and concurrent lymphatic issues, water would be the absolute best thing to make them feel better. And this is something that I've seen many, many times over clinically. But they found also then that certain activities like dance or more intense activities, because the strength and power they looked at were very, very low grade, wasn't anything that I would actually deem as really too much to move the needle on all this. But basically what they found was that it would cause more pain. It actually worsened symptoms. So throughout all of this, the research that they quoted declared that the evidence to support exercise as the conservative management of venous insufficiency is insufficient, and they need more studies to figure all this out. But I'm going to try to walk you through this. I'm going to take a couple of different studies and show why exercise needs to be nuanced in certain individuals. So the first one I'm going to walk you through is this. This is a great study done over in Houston by Dr. Rasmussen and Dr. Sedek, who I talked to on the phone about this study, where they took someone with known venous disease and we classified them according to our SEEP score, or essentially a severity or a physical manifestation scale. And they used a technology called ICG-3. And basically, it's a fluorescent dye where you can actively see the venous system and if it's working or not. And essentially what he found was that at a C3, which I'll show you that scale here in a second, you're starting to see lymphatic damage. You're starting to see lymphatic overwhelming. And that is so key, because oftentimes edema or transient edema, it just says, oh, okay, like whatever, that just happens. That's just aging, or you don't need to worry about that. But this study shows there's actual real damage that's occurring to our lymphatic system as this chronic swelling is prevalent. And I'll show you this scale. This is our SEEP classification, all the way 0 to 6. But C3, that edema, that swelling, that's the one we want to concern ourselves with, because at that point, as resolution shows, there's damage and remodeling negatively of our lymphatic system. I'll take you now to a huge consensus paper by the American Venous Forum and other groups. I'll give you this one quote, and this is this. It says, consensus was reached that clinical examination is adequate for diagnosing lymphedema, and that all patients, all patients with CVI, venous insufficiency, C3 and beyond, should be treated as lymphedema patients. Isn't that amazing? So you have someone with edema, and we need to treat them as if they have lymphedema. We need to do the things that we would typically do for that, which number one thing, it would be compression, compression, and compression. And this is going to take me to my final study that should hopefully wrap all of this up. This is a great study. It was out of Poland, and they were looking at delayed onset muscle soreness, or DOMS. If you work out, you go working out for the first time, you do some lunges, and you get that soreness 2 days later. It's hard to get out of a chair. That's DOMS. And they wanted to see what effect the lymphatic system was having on delayed onset muscle soreness. So what they took were very healthy individuals. They're younger, in their 20s, low BMI. They're runners. They run marathons. And they were screened for not having venous disease. So these are healthy, active individuals, and they do not have venous disease. And so what they did is they put them on a bike, a certain amount of wattage for 30 minutes. And then they did a bunch of different measurements. They did pressure, they did venous capacities in the toes. And what I really liked is they did ICG studies. So they were looking at the lymphatic system's response to this intervention, to this exercise, and what was happening. And this was phenomenal to that. The conclusion was this. The results showed that after 3 to 5 days after their activity, not only muscle, but also skin and subcutaneous tissue revealed major tissue fluid accumulation and overload, bringing about functional lymphatic transport insufficiency. So basically what that means, in a healthy individual, they have subcutaneous lymphatic fluid present for 3 to 5 days after that activity. Just let that sink in. Because when you then think about someone who has a compromised venous system, has a compromised lymphatic system, well, then what's happening here after they engage in activity? There's so many quotes in this study, but one that I thought was really fascinating was they were talking about something described in the literature as heavy leg syndrome. And one of the things that they correlated it to were your Merkel cells in our subcutaneous tissue, which are sensory cells that help us determine slippage and movement and things of that nature. But they found that they became more active the more swelling that occurred. So that feeling of DOMS, delayed onset muscle soreness, is extremely similar to the feeling of heaviness and achiness that occurs at the end of the day through someone who has venous lymphatic insufficiency. It's a very, very similar mechanism, both in terms of the sensory feedback, as well as the inflammatory cascade that happens within it. Absolutely fascinating. So this brings me to my final point. Here's some quotes. These are indirect proofs of interdependence of the venous and lymphatic systems in formation and transfer away of excess tissue, fluid and lymph, revealing in case of runners insufficient transport capacity of lymphatics. The feeding calves hidden edema detected only by tonometry, because you couldn't see this stuff. You had to use these different techniques to find it. And overt one seen as pinion swelling are the products of excessive tissue cap leakage Capillary filtration, go back to our capillary slides. The bulk of tissue, fluid, and lymph is produced in the foot soft tissue. So basically, all of this fluid is being created due to an overwhelming of the lymphatic system due to the high arterial venous demand. The effects of tissue, fluid, and lymph stagnation in the foot and calf are the heavy leg tiredness and decreased limb movement capacity. So who does this sound like? Our patient, Kim. It sounds exactly like that. What's going on? So here's this logical progression. Step into my mind with me. During certain activities, there's an increase in arterial and venous flow through the legs, both velocity and volume. That's what happens. We're compensating for that activity. Our body's smart. It meets the demand. There's a correlation between the stress and the duration of the activity. Many studies show this out. The higher the intensity, the longer the volume, the hotter the temperatures, the more this system is being compromised. So after endurance-based exercise, there's an increase in interstitial lymphatic fluid, which is a result of active hyperemia and increasing lymphatic load. And that this can last 3 to 5 days in a competent system. Who knows in an incompetent system? So with this, if there's vein disease, there's a compromise of venous return and potentially a progressive overload of that lymphatic system. You go back to the Rasmussen study, damage occurring to that lymphatic system, decreasing of that total transport capacity, lessening of the roads, more piles, things of that nature. So this environment can potentially be further overwhelmed through high venous load activities, doing more and more and more on top of the compromised system. So over time, this increase in venous lymphatic load can deteriorate the lymphatic system. So if this is true, then certain activities can exacerbate the mechanical functional interaction of the venous lymphatic capillary junction. So basically, adding more stress on a compromised system further damages the system. So this is our take home. So the risk of venous disease is multifactorial, as you have seen. So we have our genetics, place the groundwork, and then all those modifiable factors that happen over the course of life. And as I've also shown, prevalence is quite high and much underappreciated and underaffected. Look at that healthcare worker study, 2 to 3% only were wearing compression. So exercise can be utilized to create an environment that optimizes proper venous flow. So reducing body fat, reducing BMI, increased muscle mass, and then frequent low impact activity. Great. But if venous disease is present, certain exercises can potentially exacerbate symptoms, state by overwhelming that compromised system. So take them. Does an active lifestyle remove the risk of vein disease? Well, I would say it matters. But if it is present, it is definitely something that has to be done appropriately and smartly and much more than just go exercise. There's a lot more to it. So me personally, and what I tell my patients all the time that fall into this category is we have to utilize smart compression. So me personally, I, on a daily basis, wear 20 to 30 thigh-high compression, along with 20 to 30 knee-high compression. For the last few months, I've been using the Sigvaris Motion Flow Tech, phenomenal stocking. It fits perfectly, wiki material. It's hot here in San Antonio. And I'd be able to use it every single day during activity and after activity. The study regarding exercise and lymphatics talked about the necessity of utilizing compression after activity for recovery. And so they said they need more studies on the impact during exercise, although I think for most people it benefits them. But after it is completely undeniable. Because if you think about it, if there's all this research that shows being in a pool and swimming is beneficial for recovery, well, what's happening there is you're wearing a compression garment in the pool. And so compression garments afterwards, particularly full leg, in my opinion, to the right level of compression, would do a wonderful job for managing these sorts of patients that have this overwhelming of their venous lymphatic system post-exercise. So not only are they going to feel better, we're also going to slow or even prevent, in certain instances, the damage to that system. So utilizing smart compression and then helping them understand what activities are different. So Pilates is going to be different than a CrossFit workout. Doing marathon bike riding and running is going to be different than maybe dance or working in your garden. These are all different activities, and we need to be mindful of that because the body has to adapt differently to those different stimulus. So by doing that, it acts as a manager of the symptoms and a governor for disease state progression. And so I hope this small amount of time, because I could talk forever and I know we're coming up against the clock, has shown that there's a lot more to it than, yeah, we just need to go exercise more, but there's a lot that we can do to manage it smartly. So with that, maybe a few questions out there, hopefully, and I'll leave it at that. So thank you.
Thank you so much, Dr. Trock. Very interesting session. I see we actually do have a question that came through, so I'll go ahead and start there. And if anybody else does have any questions, you can put them in the Q&A box for us. So the question is, if compromised heart function, would it affect the managing of the compression systems? How would we manage that?
Most definitely. So if you're talking like in congestive heart failure, reduced ejection fraction, and granted it matters if it's right versus left, the first thing is that it has to be medically managed. What occurs when we are pushing more venous return is we're going to overwhelm the heart. What happens in things like CHF is it has the heart muscle itself is compromised. It cannot contract enough to accommodate the load, or it cannot speed up enough to accommodate the load for proper cardiac output. So that does need to be done smartly. I saw many of these patients when I was in home care where they had a large volume of fluid in their legs. And they need to be on the right type of medication, the right type of diuretics to manage that appropriately, make sure they're under renal and cardiac care. But it's working with those professionals to optimally move that fluid back. Because the alternative to that is allowing them to have massively swollen legs and no activity, which is not going to be good for them. And so I would ease my way into it, maybe start with a light compression that's something as low as 5 to 10. I mean, I saw some patients that were so compromised, even a tube sock actually reduced the edema in the legs, and slowly titrating the amount of fluid return into it and finding something that fits for them, all while monitoring their cardiac system. Granted, this sort of individual is not who I talked about today, but it is someone that does need proper and closer medical management, people who know what they're doing. So they're monitoring the signs for overwhelming of the cardiac system, shortness of breath, tachycardia, that sort of thing. But there is a way to do it. It just needs to be done very, very thoughtfully and step by step. But once you get them there, once they're fully reduced edema-wise in their legs and they have a better proximal return, you're no longer having that huge volume of storage of fluid in their legs to overwhelm the cardiac system. And then from my perspective, now we're optimally, if we're able to rehab them appropriately. There's one thing I never talked about in the presentation today, but if you have someone that has a really, really swollen leg, well, that impacts everything of the functionality. If I were to take any of you today and put 20-pound ankle weights on you and told you to go exercise and walk more than normal, you'd have a hard time doing that. So that's oftentimes what happens to these patients is we need them to, quote, walk more, exercise more, but never address actually the true hindrances, which is reducing the amount of weight and swelling in their legs. In addition to all of that, you got pain, you got sensory issues. There's even good research that shows that it reduces the contractility of muscle, having that amount of fluid and inflammation in the legs. So we have to address that first as we are compounding all those lifestyle changes. It's not a cookie cutter approach for each individual. So hopefully that answered the question.
Thank you. All right, we have a couple more questions that came through for you. If you have a patient that has C3 edema or higher, would you recommend a compression sock or a compressive inelastic wrap?
It matters. When we look at putting on the elastic wraps, versus a sock, the first thing I look at is the shape of their leg. Because if there's larger amounts of edema, the sock may not fit. And we all know if the sock doesn't fit right, they're not going to wear it at all. So first, the first thing we need to look at for that. The second would be the level of fibrosis. If they are a much more fibrotic patient, where it's that hard-eating tissue that's occurring in the legs, I'd much rather go with inelastic garments. Not only is it typically a better fit, but you can get a higher level of compression. They can get upwards of 15 millimeter of mercury. And I see it as having, instead of a circumferential pressure, it's more of a perpendicular pressure that to me is better at breaking up that fibrosis. The other thing that occurs is a circumference reduction. With inelastic garments, there's a certain amount of reduction you can have, and they can still wear the same garment. And so if they're a larger leg that you're going to reduce, if they're fibrotic, or if they have more of an oddly shaped leg, I tend to go with inelastic garments. I actually just had a lady yesterday that had a sclerosed ankle, tiny, tiny ankle, but hard as a rock, and then a very, very large calf. A sock would not work for that person. So what I actually did was we got an inelastic wrap, measured it to the calf size, because she was basically a medium here, but a double XL here. And I took a foam wrap and built a larger ankle for her all the way around. So we had an even slope to the leg, so it fit appropriately. And now she's going to be able to use that to reduce her fibrosis. So that's kind of my thinking behind whether I go with a sock or whether I actually go with an inelastic wrap.
Awesome. I'll sneak in one more. Do you routinely recommend exercise programs for your patients and tailor them?
Yes, virtually everyone. Movement is how our bodies were built to function. We don't retire from moving, or if we do, it goes south really fast. One of our great MPs that I worked with was a hospitalist for many years, and when he was working in the ICU, they got out of bed as fast as they possibly could, because we understand that our bodies decay when we do not move. And so I don't necessarily always use the term exercise. I use the term function. Maybe people they have a bad relationship with the term exercise, but who has a bad relationship with the term function? Who doesn't want to be able to take care of themselves in older age? Who doesn't want to be able to play with their grandkids? Who doesn't want to be able to go travel Europe when you retire? That's all function. You have to be able to do those things, much like an athlete has to be able to dribble and run and cut. They have to do those things. It's all the same thing. Those 10 physical skills that I referred to, that's universal for all human beings. The only difference is the intensity and the load and the complexity that you're doing in that. All of us squat because we all use the toilet, right? And so it's one of those things that every human being should do it. And when we look at just general recommendations, 8 to 10,000 steps a day for overall health. 6,000 is the minimum for reducing all-cause mortality in individuals under 65, 3,000 for those over the age of 65. 150 minutes a week of moderate intensity exercise. So moderate intensity exercise is anything that you can talk, but it's kind of hard. That's moderate intensity. And so 150 minutes a week is 30 minutes, 5 days a week, split between endurance-based activities. So let's say going for a strenuous walk and then strength training. And so every single human being has to do that, because if we're not training for it, then we're training for the opposite of that. And so, every single patient gets that from me, and I nuance it to them because it's vitally important. And I will tell you, if you're not doing that, you're missing out on a huge opportunity to change someone's life. If you go home at the end of the day and it's what drives you is the individual that had tears in their eyes and happiness from their family because now they're able to do things that they didn't think they used to be able to do, well, that's why we get into this business to begin with. And so, yes, movement, function, activity is something all of us should be both engaged in to represent that to our patients, as well as challenging and guiding them so they know what it is that living a good life actually is.
Well, awesome. Thank you for all of the work that you do and for hosting this webinar with us today. I saw one more question come through. I did take note of it, and we'll reach out to you individually to have a little bit deeper conversation. So yes, thank you so much for hosting today. And if you want more MOH talks, you can go to our MOH website. And for product information, you can go to sigvaris.com. This webinar will be available, the recorded version, on the MOH website. We'll also be posting it on our LinkedIn, so feel free to follow us everywhere. Thank you again, and thank you everybody who joined today, and have a good one.
Thank you.